friend Dr. Gamal Niazi. It's an honor to be with my friend and colleague Dr. Ahmed Bahaa, Professor of Obstetric and Gynecology at Shams University, one of the eminent gynecologists. We'll talk about management of uterine fibroid from the interventional point of view and surgical or gynecological point of view. Fibroids, as we know, is benign smooth muscle tumor. About 25% of all females have fibroids. About 40% of patients of females over 35 years have fibroids. It's the most common benign tumor in female genital tract, and most of them don't require treatment. Fibroid is classified into subserous, intramural, and subserosal. Symptoms of fibroids include mass effect like constipation and pressure symptoms, uterovaginal bleeding, and infertility. Treatment options for fibroid include medical treatment, surgery, and uterine artery embolization. About uterine artery embolization is a minimal invasive technique depending on injection of free flow injection of particles through the uterine artery into the uterus, depending on high flow and high perfusion of the fibroid, so the particles embolize the feeding arteries of fibroids and sparing the supply of the myometrium and endometrium. Here is the angiography for the uterine artery, descending part, transverse, and ascending. Our aim to put the caster at the proximal part of the ascending portion of the uterine artery, then free flow of injection of particles, sparing the cervicovaginal branch. We start to inject particles until stasis and devascularization of the uterine fibroid. Simply, in brief, the procedure is access through the femoral artery, then we pass with the caster and guide wire into the uterine artery, start classically from the contralateral side, then we put the caster at the ascending part of the uterine artery, starting injection, free flow injection of particles, until stasis of the feeding artery. Here is an example for angiography, and this is flush angiography. This is the vascular blush of the fibroid. Here is vascular blush fibroid before embolization. Started by catheterization of the left uterine artery. This is before embolization. This is after starting partial embolization of the left uterine artery. And this is the image after complete embolization of the left side with complete stasis and devascularization from the left side. Then ipsilateral catheterization of the right uterine artery. This angiography after partial injection of particles. More and more injection. It is the final image after complete devascularization of the uterine fibroid. And there is an image after complete devascularization, complete absence of the vascular blush, which was noted before embolization. And here is the final image after embolization. Another example for embolization, some authors try to do synchronous embolization from the right and left sides. We do puncture from right femoral artery and left femoral artery, then casterize both right and left uterine arteries, and start injection of the particles at the same time. And this is the final image after embolization of both and right and left uterine arteries. Outcome of the uterine artery embolization is successful technically from 90 to 80 to 99%. Successful in controlling menorrhagia in 80 to 90%, controlling bulk symptoms in 80 to 90%, reduction of fibroid size from 40 to 80%, reduction of uterine size from 40 to 60%. More than 90% satisfied with procedure, reporting significant improvement of quality of life, and in some cases, this is before embolization, this is after embolization, devascularization of the fibroid. Another example is this is large fibroid before embolization, and there is reduction in size after embolization. This is anterior wall fibroid before embolization, and this is after embolization. Sequential MRI for fibroid. This is pre-embolization with enhancing fibroid. This is after 3 months, after 6 months of embolization, and for 1 year. Marked reduction of the size of the fibroid. So, regarding the debate between uterine artery embolization and surgery for treatment of the fibroid. Now, after 15 years of study, clinical experience in uterine artery embolization, this is a lot of documents and papers was done to compare between surgical treatment and interventional treatment. and studies the efficacy and efficiency of embolization in treatment of uterine fibroids. Here are examples for some papers and studies was published about the comparison between uterine artery embolization and surgical treatment, either hysterectomy or myomectomy. It is one of the largest studies which updated up to September 2021, which included 7 studies at the same time, 793 patients compared to surgery. As compared to surgery, uterine artery embolization has reduced the length of the procedure, hospital stay, and the time of resumption of routine activity. The patient satisfaction was similar between uterine artery embolization and surgery. Uterine artery embolization is associated with a higher rate in minor post-procedure complications and higher unscheduled visits, but has no difference in major complications after 1 to 5 years. The rate of further surgical intervention was higher with uterine artery embolization. There was a high proportion of complete asymptomatic women after myomectomy than uterine artery embolization, but the difference was not significant. Another study was published at the American Journal of Obstetrics and Gynecology, which concluded that uterine artery embolization has a short-term advantage over surgery. On the mid and long-term benefits were similar, except for higher intervention rates at the uterine artery embolization. Another study published as the Gynecology Oncology paper talk about comparison between embolization and surgery and concludes that compared to surgery, uterine artery embolization has a shorter hospital stay, shorter recovery time, and less major complications. More studies are needed to talk about the infertility. This is the last study was about the comparison, which concluded that in symptomatic fibroids, faster recovery after embolization must be weighted against need for further treatment in the minority of patients. Regarding the uterine artery embolization and fertility, we postponed the talk about this issue with my friend, Dr. Ahmed, to talk about this process.
Okay, thank you very much, Dr. Waleed. First, I wish to express that it's a great honor to be in this event and to have a little talk with in front of this elite group of doctors. Actually, I'm very impressed with these interventional radiology procedures, especially uterine artery embolization. I saw a patient who saved her uterus after an attack of postpartum hemorrhage due to morbidly adherent placenta. But after that, on the other hand, she never got pregnant, even after 2 trials of ICSI. So my concern here is that the generalized ischemia, which happens after bilateral uterine artery embolization, it has definitely has an impact on future fertility and pregnancy. There are cases who got pregnant after uterine artery embolization for fibroids, although they are limited number of cases, but many complications were noticed in these cases. So what I'm talking about now is how to optimize the results of uterine artery embolization to reach the great results is after proper selection of the patients and after contribution between the gynecologist and the interventional radiologist to obtain optimum results and to avoid the complications. The first patient, which is not a candidate for uterine artery embolization for fibroids, are these women who have future reproductive ambitions. Preterm delivery, spontaneous abortion, abnormal placentation, and postpartum hemorrhage all are increased following uterine artery embolization. We see in this table comparison of pregnancy outcomes in the general population and after uterine artery embolization. Spontaneous miscarriage is 3 times more than the general population. Postpartum hemorrhage, preterm delivery, cesarean section, all these complications are doubled or tripled in comparison with the general population. The rates of spontaneous abortion in pregnancies after uterine artery embolization for fibroids are 33%, which compared to the untreated cohort with myomas, meaning that if you leave the myoma alone, 16.5%, and compared to 4.5% in those with a normal obstetric cohort. Similar results in premature birth ratios and malpresentations and cesarean section rates and severe postpartum bleeding. There are possible mechanisms by which UAE could influence pregnancy progression. Most of them are related to the generalized ischemia induced in the uterus. Reducing ovarian perfusion may lead even to premature menopause. Reducing perfusion of the myometrium and the endometrium, of course, may affect the endometrial receptivity and affect pregnancy rates. The devascularized areas in the myoma, sloughing of the myoma, infection of the myoma, all of this make the uterus not suitable for pregnancy or for the continuation of the pregnancy. In the clinical recommendations of the Royal Colleague of Obstetricians and Gynecologists, and also in the American Colleague of Obstetricians and Gynecologists, they mentioned some disadvantages of the procedure, although they admit that it is a good procedure and an alternative for many women who may not opt for surgery. Mainly non-response, pain after the procedure, 1 to 2% chance of serious complications that may need immediate hysterectomy, infection which may occur later, and cycle disruption and potential for premature ovarian failure, mainly non-target embolization, which is very rare, especially with skilled interventional radiologists. I will not go through the complications, but I will discuss the ideal patient for UAE and those who are contraindicated or relatively contraindicated for UAE. Those who are relatively contraindicated, of course, if there is an evidence of pelvic infection, if she is pregnant, if she is not accepting the small risk for the requirement of hysterectomy in the event of infection, if there is a doubt in the diagnosis of a benign pathology, or if there is a desire for future fertility. There are some myomas which may not respond well to this procedure, such as very large fibroids with bulk symptoms where the size reduction may not be sufficient to meet the patient expectations. Those pedunculated fibroids, whether submucous or subserous. Do you want to say the conclusion? Okay. We both agree that UAE is a reasonable option for women who wish to preserve their uterus and avoid surgery and a prolonged recovery period, and it has a very low complication rate if the patients were properly selected. Of course, hysterectomy as the surgical option has 100% cure and zero risk of recurrence. So we may compare the procedure with other surgical procedures such as laparoscopic myomectomy or hysteroscopic myomectomy. The use of uterine artery embolization is rarely, if ever, indicated. Patients should be assessed, and this is the most important point I want to stress on, by a multidisciplinary team, including a gynecologist and interventional radiologist, to ensure the appropriateness of the therapy and consider the reproductive wishes of the patient. Patients considering uterine artery embolization should be adequately informed about potential complications. Thank you.
Thank you, Dr. Waleed. Thank you, Dr. Ahmed, for such uterine fibroid session. And I think the questions will be after the end of the session. Now, I have the honor to represent Dr. Gamal Niazi and Dr. Sharif Ishaq for their session, Preoperative Embolization of Vascular Bone Tumors, Case-Based Discussion.
صباح الخير على حضراتكم جميعا. نرحب بكل الموجودين